Hi, this is Kari Stevens. I'm a clinical psychologist at the University of Washington.
And this is Patrick Raue. I'm also a clinical psychologist at the University of Washington.
And we're excited today to teach you about cognitive behavioral therapy for anxiety, or what we're calling CBT-A.
So these are our learning objectives for today. First, to understand the CBT model of anxiety symptoms. Next, to describe how to give the treatment pitch to patients and discuss the difference between treatment with exposure versus anxiety management strategies. Third, to understand how to develop and work on an exposure hierarchy with patients. And lastly, describe anxiety management strategies that use physical and cognitive approaches.
In this training, we will review skills and techniques that you can use to understand and treat anxiety. Anxiety is actually the most treatable and common mental health condition we know of today, and treatments are highly effective and well studied over many decades and work with complex patients in primary care. But the problem with treating anxiety is that it can require patients to expose themselves to some of the situations that can really scare them the most. So clinicians have to be able to distinguish and teach clients how to identify anxieties that are unfounded, meaning the thing that the client is the most scared of is actually very unlikely to happen, from actual anxieties that would occur for any human being. For example, a realistic threat of being evicted or harmed or going to prison. So clinicians also have to use their best clinical skills to determine whether the client is willing to engage in exposure and support them to do this exposure. If they're unwilling or unable to do it at the start of treatment, you can teach them anxiety management skills like breathing, deep breathing, relaxation, stress management, things that help them engage in the treatment itself and later on succeed at doing exposure down the road. So this is really going to require creating a clear pitch to the patient and the client, rather, of what they want to do in this treatment, coming up with a treatment plan and goals that will be essential for both the clients and the therapist to feel energized and enthusiastic about anxiety treatment.
In this training, we will use a modular approach to treatment. And what this means is that you can apply these strategies regardless of anxiety conditions. We'll give you the basic pieces to the puzzle, and you can decide with your patients how to put them together. This type of modular CB treatment is for all anxiety conditions, including those listed on the right-hand side. And for all of these conditions, exposure, as Kari mentioned, is the most effective treatment component. This is what will result in reducing patient anxiety. The anxiety management techniques like the relaxation and the imagery and the cognitive restructuring should help patients to manage or live with their anxiety better, but do keep in mind that these techniques are not as powerful as exposure in actually reducing anxiety severity.
So Patrick and I want to make sure that we can anchor all of this on a particular case example to help you think this through. So let me talk to you about TC, who is based on a patient I actually saw. So this is a 52-year-old Caucasian female who's married, who was an administrative assistant, and she's been unable to work since pain began after she had a head injury at work when something fell and hit her in the head. When she came in for treatment, her key complaints were that her scalp tingled and her head hurt intermittently, not all the time, but it sort of came and went, and that she couldn't work out anymore physically because it caused pain flares to happen. Noises, she also said, made it worse, and even going out to eat could be difficult, mainly because of all the noise in the restaurant. Her average pain rating when we asked her on a scale of 1 to 10 was 7 out of 10, and she said she had moderate anxiety symptoms that she said to some degree intensified after the accident at work, and she really had minimal depressive symptoms. So now I want you to keep this case in mind of TC as we walk you through the 4 different steps of CBT-A. The first step here is going to be to explain the cognitive behavioral therapy model of anxiety, which we'll walk you through in a second. The second step is to determine the patient's treatment goal, and we do that by asking questions about how anxiety is interfering with their lives and what they would like to see different. So this isn't what we judge and think the patient should be doing or what we think is being interfered with anxiety, but rather what the patient reports is really the interference. And then step 3 is to give the treatment pitch. That is to discuss with the patient what exposure is and how it can reduce anxiety, and really give them a strong sense of how this is going to help them in their life. You also, at this point, will talk about what management strategies are for anxiety and how they can help us live with anxiety, but also about how they don't necessarily treat anxiety in the sense of really helping it go away over time. Then in the fourth step, you're going to develop and work through an exposure hierarchy, and we'll discuss how the exposure exercise can be done, either in real life or potentially in the patient's imagination. Anxiety management strategies are taught as needed. For example, if the patient does not feel ready to engage in a certain kind of exposure, then you can use anxiety strategies as a way to help get them prepared to do the exposure. So let's talk about the first step, explaining the CBT model of anxiety to patients.
When we start to educate our patients about what anxiety is, it's first helpful to distinguish between fear and anxiety. Fear is a response that we all have to a known or a definite threat. So when we perceive a threat, our bodies automatically have a fight or a flight response. And from an evolutionary perspective, this response has been necessary for our survival. Anxiety, on the other hand, occurs when we experience a fear response in the absence of a clear danger. Now, anxiety can be a positive or a helpful response if it kind of activates us and gets us going, and it's not too severe. Anxiety becomes a negative or a harmful response if it's chronic and if it gets in the way of what we want to do.
So Patrick and I now are going to walk you through the basic cognitive behavioral therapy model of anxiety. And so the way that we like to present this really is in this triangle you see here, where the triangle represents anxiety. And you'll see at the different points of the triangle these physical sensations and thoughts and behaviors that really flow with each other and sort of can reinforce over time and have anxiety increase. So at the top, you see physical sensations, which is really about anxiety being a physical response in the body. There are lots of things that we feel when we get anxious, whether it's a racing heart, shortness of breath, sweating, flushing, our throats tightening, all kinds of physical sensations that happen. At that same time, when we get anxious, there are also thoughts that will race through our head, and that's sort of our perception of threat or the different scary things we think are going to happen. For example, if we're in a social situation that makes us anxious, worrying that we're going to be perceived in a bad way, thinking maybe I need to make an excuse and get out of here, for example. The behaviors are really what we do that seek safety. So when our body is getting really anxious and our brain is going actively crazy with different scary thoughts, the behavior then naturally is that we want to avoid what's happening there and go reduce that anxiety and seek safety in some way.
And to bring that CBT model to life with patients, we want to ask the patient to think about a situation where they experience some significant anxiety. And sometimes it's easiest to think about this CBT triangle as the 3 B's: body, brain, and behavior. We want to ask our patients to tune into the 3 B's for them. First, what did they feel in their body when they got anxious? What did they think when they got anxious? And then what did they do when they got anxious? And that's basically step 1. We're going to share with you in a bit what TC had to share for her 3 B's.
So now I want you to keep this case in mind of TC as we walk you through the 4 different steps of CBT-A. The first step here is going to be to explain the cognitive behavioral therapy model of anxiety, which we'll walk you through in a second. The second step is to determine the patient's treatment goal. And we do that by asking questions about how anxiety is interfering with their lives and what they would like to see different. So this isn't what we judge and think the patient should be doing or what we think is being interfered with anxiety, but rather what the patient reports is really the interference. And then step 3 is to give the treatment pitch. That is to discuss with the patient what exposure is and how it can reduce anxiety and really give them a strong sense of how this is going to help them in their life. You also, at this point, will talk about what management strategies are for anxiety and how they can help us live with anxiety, but also about how they don't necessarily treat anxiety in the sense of really helping it go away over time. Then in the fourth step, you're going to develop and work through an exposure hierarchy, and we'll discuss how the exposure exercise can be done, either in real life or potentially in the patient's imagination. Anxiety management strategies are taught as needed. For example, if the patient does not feel ready to engage in a certain kind of exposure, then you can use anxiety strategies as a way to help get them prepared to do the exposure. So let's talk about the first step, explaining the CBT model of anxiety to patients. So here are some ideas for how you can go about doing this. When anxiety is harmful from the patient, what you need to find out is, when does this anxiety actually happen? So keep in mind that this is where you're discovering the cues or the triggers to this person's anxiety. What you really want to find out is, what are the situations that are triggering that anxiety, when during the day is that happening, and what are they tending to think, and what are they doing when that happens. The second important piece that you need to figure out is, what does anxiety get in the way of? This is really getting the patient's perspective, because it's going to be your key to finding their motivation to go and do this anxiety exposure, which actually is going to make their anxiety worse in the moment before it makes it better. So you need to ask, what can't they do because of the anxiety? Or how does this anxiety really hold them back? And what do they do when they avoid? Because again, these are going to give you those crucial clues you need to keep your patient motivated to do this treatment.
All right, so as promised, here are the 3Bs for TC, Kari's case example. And remember that this is a woman who really valued working out, and that was a big part of her life. And when Kari asked her to think about a situation that brought about anxiety, just thinking about getting back on the treadmill, working out, caused a lot of anxiety. And when we asked her to tune into where she felt that anxiety in her body, she reported that her scalp tingled, her head hurt upon any kind of exertion. When we asked what she was thinking at those times, she reported having thoughts that, any kind of physical activity is dangerous for me. And if my pain starts, I'm not going to be able to tolerate that. When asked what she did in response to those cues, she would avoid all physical activity. She would also avoid any kind of social situations where there might be noise.
So now I want you to keep this case in mind of TC as we walk you through the 4 different steps of CBT-A. The first step here is going to be to explain the cognitive behavioral therapy model of anxiety, which we'll walk you through in a second. The second step is to determine the patient's treatment goal. And we do that by asking questions about how anxiety is interfering with their lives and what they would like to see different. So this isn't what we judge and think the patient should be doing, or what we think is being interfered with anxiety, but rather what the patient reports is really the interference. And then step 3 is to give the treatment pitch. That is to discuss with the patient what exposure is and how it can reduce anxiety, and really give them a strong sense of how this is going to help them in their life. You also, at this point, will talk about what management strategies are for anxiety and how they can help us live with anxiety, but also about how they don't necessarily treat anxiety in the sense of really helping it go away over time. Then in the 4th step, you're going to develop and work through an exposure hierarchy, and we'll discuss how the exposure exercise can be done, either in real life or potentially in the patient's imagination. Anxiety management strategies are taught as needed. For example, if the patient does not feel ready to engage in a certain kind of exposure, then you can use anxiety strategies as a way to help get them prepared to do the exposure. So let's talk about the first step, explaining the CBT model of anxiety to patients.
So in giving the treatment pitch, we want to describe to patients that first, there are strategies to help treat their anxiety or to actually reduce it. And there are some separate strategies to help them manage or live with the anxiety to the best that they're able to. Anxiety can be reduced if the fear is actually not as dangerous as it seems. We can think about high levels of anxiety being due to the brain being an overly sensitive alarm that goes off too soon, when there really isn't any kind of danger. And gradual exposure is a technique that can actually reset the brain in a way and relearn that certain situations are not as dangerous, and really we don't need an alarm there. Alternatively, anxiety can be managed or better tolerated with some coping skills like the deep breathing or relaxation training or some of our cognitive strategies. These techniques should be used when the fear is actually dangerous, like going down a dark alley by yourself at night. Or they can be used if the patient is not ready to face the fear head on.
So let's go back to our picture of the triangle and sort of take in what Patrick is saying here, where you can actually draw a line down that triangle and put management really on that left side, where you see managing anxiety and learning better coping fits really well with learning to manage physical sensations through things like relaxation strategies, or managing anxious thoughts like the cognitive strategies that we might use. But really, both of those approaches are really going to help a patient live better with anxiety over time and not necessarily take away or neutralize those anxiety triggers. Whereas on the right side, we really have the treating anxiety piece. And sometimes I'll even draw this out on a piece of paper for a patient and just draw a line straight through that triangle and explain to patients that the treatment that we really want to go for is doing exposure, which is going to tackle head on those kind of avoidant behaviors and turn them around and really have patients instead stay in those situations so that their brain gets a chance to relearn that those alarm bells that are going off really aren't necessary over time. Now, as Patrick said, the management strategies can be really helpful to tolerating the exposure or to just getting engaged in treatment. One concern that we have is making sure that people aren't only doing management strategies, because sometimes inadvertently just doing management can actually reinforce anxiety over time.
This slide further describes how exposure allows the brain to unlearn what it perceives as being overly dangerous and to actually create new learning. It's important to ask, what does the brain need to learn in order to neutralize that alarm or that situation that isn't truly dangerous? Let patients know that exposure is a gradual process of approaching feared situations and triggers. Approaching these triggers without trying to escape or without engaging in safety behaviors will lead to a reduction in anxiety over time. Now, usually this requires multiple exposures to the same trigger in order for anxiety to decrease over time. And it's important to know that the amount of time it takes for this to happen can really vary widely across clients.
So keep in mind, exposure really is all about laying down competing memory for those old dangerous memories that the patient has. And that's why it really can vary widely and take time and practice to really create enough new memory to combat the old ones. So one of the things that's going to be important to discuss with patients that you're treating for anxiety is that safety behaviors can also maintain anxiety, and that they may feel really good in the moment or give temporary relief, but that ultimately those safety behaviors can hurt us later, because the brain unfortunately maintains the connection between what it sees as dangerous. So let me give you an example. Let's say you're afraid of flying, and everyone has told you 5 million times how safe it is, but you are still afraid when you get on that plane. I'm sure many of us know someone who feels that way or maybe have been that person ourselves. So let me go through some examples. You might seek reassurance. You might go on this plane and look around to see if anyone else is looking terrified. And if there's a bump to get reassurance, you look and see that nobody panicked. Unfortunately, your brain learns that you were safe because no one panicked, not because the flying was actually safe. So reassurance is actually not necessarily a good way to deal with anxiety. Behavioral rituals might be another strategy you use. You might sit in a certain seat, like in the front so you can run out, or close to an exit door, or in the back because you think for some reason that was safer. You might have some safety cues or objects that you look into. For some people, they might bring a Bible. They might bring water to drink. Lots of distraction. Alcohol is a great one that people use on airplanes all the time, or everyone's favorite safety cue, Xanax, that they get from their doctor. Or you can go through over-preparing. Over-preparing is a hard one to do for flights, but you might see this safety behavior with someone with generalized anxiety disorder, where people are overworking and over-preparing to make sure that things are perfect and won't fail.
As we're getting to the end of step 3, let's visit TC. For TC, the pitch involved determining the treatment target. In other words, what was most important to her. For TC, her treatment target was anxiety about pain flares, because these pain flares were what was keeping her from working out and even getting back to work. So the treatment for TC would primarily involve gradual exposure to the situations that increased her anxiety. In her case, any physical activity, which, remember, is what led to her pain and her catastrophic thinking about that. In TC's case, she was willing to do the exposure, so we wouldn't focus on the anxiety management strategies.
So now I want you to keep this case in mind of TC as we walk you through the 4 different steps of CBT-A. The first step here is going to be to explain the cognitive behavioral therapy model of anxiety, which we'll walk you through in a second. The second step is to determine the patient's treatment goal, and we do that by asking questions about how anxiety is interfering with their lives and what they would like to see different. So this isn't what we judge and think the patient should be doing or what we think is being interfered with anxiety, but rather what the patient reports is really the interference. And then step 3 is to give the treatment pitch. That is to discuss with the patient what exposure is and how it can reduce anxiety, and really give them a strong sense of how this is going to help them in their life. You also, at this point, will talk about what management strategies are for anxiety and how they can help us live with anxiety, but also about how they don't necessarily treat anxiety in the sense of really helping it go away over time. Then in the 4th step, you're going to develop and work through an exposure hierarchy, and we'll discuss how the exposure exercise can be done, either in real life or potentially in the patient's imagination. Anxiety management strategies are taught as needed. For example, if the patient does not feel ready to engage in a certain kind of exposure, then you can use anxiety strategies as a way to help get them prepared to do the exposure. So let's talk about the first step, explaining the CBT model of anxiety to patients.
So this slide discusses how to actually conduct exposure exercises. First of all, the patient should always be involved in making decisions about what kind of exposures to do. We should never surprise the patient with an idea about an exposure. He or she needs to always be in the driver's seat when picking homework assignments and moving up on the hierarchy. So we start by asking the patient to work with you to create a list of at least 1 or up to 3 situations that the patient is currently avoiding that he or she would actually like to face and see some improvement on. We structure this using what we call a hierarchy. This is an ordered list of triggers that range from the easiest to the hardest. Keep in mind that these situations need to be specific because the ultimate goal will be to have the patient practice them in real life. So if somebody started their list by saying physical activities as something that's a trigger, that's a good start, but we can get more specific. We can help them to specify a clear set of chores at home, for example, or a particular exercise. And also we want to make sure that the behaviors include ones that the patient can realistically change. Typically, you would ask the patient to first start with a situation that is lower on their ranking of distress or anxiety. And this is because it's important for them to experience anxiety, see that they can handle it, but not be so overwhelmed that they try to escape from the situation or never even start the exposure exercise.
So now let's put into practice what Patrick just talked about and go through TC's case and how we worked with her to create her hierarchy for her anxiety exposure exercises. So remember that she had a head injury, and she also had a lot of fear around more headache pain that would flare up, especially with any kind of physical activity. She was really worried that any of this activity would directly cause a pain flare and avoided pretty much most activities generally throughout her day. So household chores like twisting and moving her head resulted in mild to moderate anxiety levels, while moving more vigorously in different ways like jogging and running, which she really used to enjoy doing, resulted in a lot more severe anxiety for her. So as you look through this hierarchy, you'll see that we had her rate from 0 to 10, her anxiety related to different kinds of physical activities. And this really was to help her brainstorm where she could begin her hierarchy exposure. You see that we've highlighted level 4, which is walking into the kitchen and unloading the dishwasher. which was a good level to begin with because it wasn't too high that she might want to avoid doing the exposure itself, and it wasn't so low that she wouldn't noticeably feel some of the anxiety that she experiences. So we'll talk in a little bit about what to do when you actually have her do that exercise. So before Patrick and I go into more specifics about what you want the patient doing during their exposure, let me talk a little bit about what your role is as the therapist and what you would do to support your patient doing this kind of exposure work. First of all, you want to encourage them, of course, to engage in it, which can be hard because they might have little buy-in or they might just be very worried and anxious about doing it. So do all of the encouragement you can to convince them that this really is what's going to help reduce their anxiety. You want to also help them maintain their focus on the trigger. This can be really tricky because sometimes you think you've got that trigger, but what you might not realize is that the patient is actually getting into a lot of different thoughts that can become their own triggers in addition to the activity that you've assigned them. So sometimes this can be a little tricky, and you can see people's anxiety going up and up and up, but what you don't realize is that it's because they haven't sort of narrowed the one trigger and they've sort of stacked on other hidden triggers along the way. You can also assess their internal reactions by having them practice periodically rating their own anxiety and figuring out on a scale of 1 to 10 how anxious are they as they're doing an activity. You can model that in session by asking them what their anxiety level is and help them target about a 50% reduction in their own anxiety rating while they're doing that exposure. But really what you want to see is a significant drop in the anxiety while they're doing the exposure, as opposed to worrying about whether it's exactly 50% or not. You also want to point out any avoidance and help the client refocus on that trigger if you see them sort of do things to steer away from it or avoid engaging in it, and provide encouragement and validation during an exposure and praise and reinforcement afterwards when you're able to do that in session with the client. And then the last piece is kind of on our own side of the fence. You don't want to distract the client because doing exposure with patients can be really hard. And sometimes we have bad feelings too when we're watching our patients get anxious and we know that we're asking them to do that thing that's making them uncomfortable. It can make us uncomfortable and we avoid that. So try not to distract them or overly comfort them during that, but rather encourage them and let them know you're right there supporting them.
So here's an example of an exposure homework that our patient TC might complete and record through the week. You'll note that this is an exercise that she can do in the home. We do try to arrange an exposure exercise that we can do in session to kind of demonstrate the process and get the patient more comfortable doing this. So we might think of an analogy to what the patient chose to do at home, unloading the dishwasher, and that might be to, arrange some piece of paper on a chair or on the floor that the patient we could walk through the patient practicing what this exposure homework might look like so she's more comfortable with it. Once we do that, we have a homework assignment, and TC would start during her first week with unloading the dishwasher. And remember, she gave that an anxiety rating of a 4. And we ask her to log her anxiety level at 3 different time points when she actually does this. First, before beginning the activity. Secondly, during the activity. And finally, after she completes it. And note that we encourage the patient to do at least one homework exposure exercise a day. We should note and call attention to the patient that we expect her anxiety ratings during the activity to be somewhat higher than before starting. And the reason that we have that expectation is that she's going to be experiencing physical sensations in her head, on her head, while she's unloading the dishwasher, and we expect her to worry about that. That's going to trigger anxiety about her head injury and increased anxiety associated with that. We're going to encourage her to stick with that activity until she notices a significant drop in her anxiety level. If she stops unloading the dishwasher before this point, remember that's going to reinforce the relief associated with avoiding that activity. So by continuing until our patients experience a lowered anxiety, that helps them remember to retrain the brain and really dampen that fight or flight alarm that's associated with head discomfort in TC's case. Now, once TC has shown repeated successful exposures to that activity of unloading the dishwasher, then and only then do we encourage her to move up to the next activity in her fear hierarchy. In her case, that would be doing several chores back to back, like unloading the dishwasher, picking up toys, and putting laundry away.
So now let's back up a second and think about, when are you going to use anxiety exposure treatment with your patient? We want to look at the process of exposure really being similar across the different anxiety conditions. And the thing that you're going to think about varying across these different anxiety conditions is the fear trigger itself that varies. So the reason it's going to be helpful for you to figure out which condition you're dealing with when it comes to the anxiety issue with the patient, whether it's simply fear around pain that's happened, or whether you've got a more substantial mental health condition around anxiety, you might see that there are different triggers involved. So with separation anxiety, that's typically with children, you'd see it's any kind of separation from the caregiver that's the typical trigger. With a phobia, it's usually a feared object or situation of some kind that triggers that particular phobia. If it's social phobia, then obviously it's the social or performance situations. If it's panic or agoraphobia, it's generally a physical sensation of panic in the body that's actually the trigger. So that's what you want to do exposure around, is some kind of physical sensation that feels like panic before they're actually panicking. If it's generalized anxiety, then it's really about worry kinds of scenarios, which typically are thoughts. So it's really about doing exposure to those anxious thoughts that come up. If it's trauma-related anxiety, then it's really trauma-related triggers or memories or places or things that trigger those trauma memories that you want to do exposure with. And if it's obsessive-compulsive related issues, then it's really the obsessions or obsessive thoughts themselves that you have to do the exposure to. So you can see it really depends on what the condition is to help you hone which kind of trigger you're going to go after with your exposure treatment.
All right, so let's shift now to talking about anxiety management skills. And if you remember our 3 Bs, we can look at some strategies that target the body's physical sensations. So remember, if a patient is having a hard time doing the exposure, that's when we consider kind of upping the management strategies to help keep them in the exposure and not avoid it or terminate it too quickly. Remember, of course, if patients absolutely can't tolerate any kind of exposure, then you can move directly to anxiety management strategies.
So one of these coping strategies is relaxation. And let's just start here with some psychoeducation. Relaxation skills do target the physiological reactivity, or basically the body's responses to anxiety. The 2 main skills typically that help the best with that is what we call diaphragmatic breathing, which targets kind of that acute sort of panic reaction. So that deep breathing where you get that diaphragm to move, or progressive muscle relaxation when the patient has more time and sort of ability to lay down and relax more thoroughly. And that can target chronic muscle tension that often also comes with ongoing anxiety and worry, as well as help actually with pain management. It's important to really be realistic about how effective these skills are in reducing anxiety. I often let patients know this can help you some and really make anxiety more tolerable, but it doesn't necessarily stop anxiety from happening or reduce anxiety a whole lot for a patient. The skills are taught and applied similarly across all the anxiety conditions, so that's the good news.
So to start with, diaphragmatic breathing is a pretty straightforward and helpful method to reduce physical symptoms such as those that we list on the left-hand side, like increased heart rate. We do provide some videotape examples at the end of this webinar that you can refer to kind of see an actual demonstration. We also encourage you as clinicians to practice this first before you try to teach patients. It helps you feel more comfortable and confident. But we instruct patients in this type of deep breathing by following the instructions on the right. So we encourage patients to take slow, controlled breaths into the diaphragm. so that their stomach should be moving and not their chest when they inhale. We ask patients to inhale and exhale at about the same duration, about 3 seconds each. And we let patients know this can really take a lot of practice before it feels natural. So they should practice this every day. And it's really important to try this out first when they're not experiencing stress or anxiety. We want them to feel comfortable and like they've mastered this technique before they try it out in a situation where they feel stressed.
So in addition to deep breathing and relaxation strategies, there's lots of other physical strategies that you potentially can use. Many of you clinicians may already know how to do some of these things, or you can refer patients to engage in these types of things. So we've got a list here. This is not exhaustive. There are certainly other things you could think of as well that potentially can help bring anxiety down generally. The key again is to keep in mind these really are all management strategies for anxiety, not necessarily full treatment strategies. So they're great things to do, especially if they're in service of helping people do exposure.
And now we can move to thoughts and some anxiety management skills that target how we're thinking or how we're interpreting what is dangerous.
So one of the strategies we use to help people with anxious thinking is a fancy term called cognitive restructuring, which basically means learning how to challenge and change their thoughts to being more balanced. So it's really a process of identifying and evaluating and changing unhelpful and maladaptive thoughts that really aren't helping somebody move forward. Its goal is really to generate, again, like I said, more balanced or accurate kinds of coping thoughts that are less anxiety provoking, but of course are still very believable to the client. So really thoughts that can be better supported by evidence as we sit back and think about what is supporting that thought. We can instruct patients to rehearse these kinds of coping thoughts before they're in anxious situations, and this can help decrease sort of their anticipation of the anxiety, as well as during the actual situations that cause the anxiety. And it can help decrease that in-the-moment anxiety that many of us can relate to. So with repeated practice, clients generally start to think in a more balanced way, more automatically, and with less intentional effort. So in other words, it gets easier over time as they practice. It's really important to stress that this process is not just thinking positively. This isn't about turn the frown upside down, but it's really about thinking in a more realistic or helpful way. So there are a few different cognitive distortions that are worth mentioning that are sort of patterns of thinking you'll see commonly come about when you're working with your patient. So in general, there are a couple I want to go over. One is overestimating the likelihood of negative outcomes, which basically means you may be seeing that they jump to conclusions a lot, or basically expect that worst case scenario. That's something we also call catastrophizing. There are common distortions that are also commonly seen in specific anxiety disorders, and a couple of examples you'll see on the right here. So with social phobia, we may see mind reading, where we actually believe that we know what others are going to do and are going to judge us negatively before we've even entered the situation. And with obsessive compulsive disorder, there's actually this fusion between the thoughts and the actions that come together, where the belief and the thought of actually yelling out, for example, is the same as actually doing that in real life. So let me review a couple of quick strategies for doing this kind of cognitive restructuring for two of the most common patterns you'll see. So the first, again, is that overestimating the likelihood that negative things are going to happen. The goal really there is for you to help them identify all other possible outcomes, to help really determine what the real odds are of the feared outcome as a strategy to help them recraft a more balanced thought. For the catastrophizing patterns that you'll see, your goal really is to assist your patient in generating a list of ways to cope with the worst case scenario. So helping them see that there are lots of things they can potentially do to deal with those big fear thoughts.
So Kari spoke about cognitive restructuring as one set of strategies for addressing sort of distorted or unhelpful thinking patterns or ways of interpreting events or situations. This slide lists a number of other coping skills that also target distorted thoughts that you may find helpful. For example, mindfulness, problem solving, strategies for scattered thinking or forgetfulness. You can help your patients address habits of poor or impulsive decisions, and also thought stopping, some sort of simple technique to help patients kind of cut off worried or anxious thoughts when they experience them. All right, so as I noted earlier, we wanted to provide you with a number of videotaped demonstrations so you can see examples of how many of these strategies are conducted. So we have how to develop a fear ladder or a fear hierarchy and set up those exposure exercises. We have a couple of examples about how to do diaphragmatic breathing. And these last two, examining the evidence and devil's advocate, are examples of different ways to do cognitive restructuring.
Patrick and I would like to thank you very much for listening today.